Hello everyone. Today we are joined by Dr. Oluyemisi Famuyiwa, and she's the author of The Quest for Fertility. She's also the medical director of Montgomery Fertility Center, an assistant clinical professor at obstetrics and gynecology at the George Washington University School of Medicine and Health Sciences. Dr. Famuyiwa is a board certified reproductive endocrinologist and infertility specialist known for her thoughtful, evidence-based, and culturally informed approach to fertility care. Today's webinar, inspired by her newly released book, The Quest for Fertility, will explore reproductive health and informed decision-making through the lens of reproductive biology. The discussion will begin with reproductive timing and egg physiology, followed by an exploration of the recent shift from PCOS to PMOS and with this evolving understanding may mean to reproductive and metabolic health. The session will also include a patient experience segment, followed by audience questions and discussion. Welcome, Dr. Yemi.
Thank you so much. Thank you for that. I want to thank everyone for coming on this evening. I know you have other things you could be doing, such as dinner, so I do not take your time for granted. I appreciate your joining us. So I'm going to share my screen and then share a slideshow. It's not meant to bore anyone. Please don't fixate on the mechanisms because our audience is mixed. We have both patients, we have a lay audience, we have GYN residents, and we actually also have practicing endocrinologists in this audience. So it's mixed. And I'm going to try and tailor it a little bit for everybody, explain. So do not get caught on the terminology or mechanisms, but I promise you I'll do my best. So with that said, I'm going to share my screen. So that's the book. It took 3 years to birth this book with a lot of labor pains. Let me tell you, they almost had to do a C-section to cut it out, but I pushed it out. Anyway, so we're getting started. My name's Dr. Famuyiwa. I'm so happy you're here. And we're going to get started with, the goal of today's talk is explain what the egg physiology is briefly, and then we're going to do a deeper dive into the PMOS change, PMOS. If you have questions, please send the questions to the host and panelist. Merlin, who you met as our office administrator, is taking questions, but there will be a broader question and answer session at the end. I just wanted to bring this reality to fact that many people do not realize that their day-to-day living is actually deciding for them what their fertility reality will become in the future. So let me tell you, it's a reality. So, and these are some of the myths that people are carrying on. So I'm going to ask Merlin to pop the first poll question here. This is interactive for you guys. Merlin, can you put the first poll question? Let's see how many people can answer this. And we're going to give you a few seconds before we end this poll. Let's talk about the egg before I go into PMOS. What is the egg really? You know, the egg is the biggest cell in the human body, right? It has to be big. It's about 5,000 times by volume the size of the tiny sperm that you see. You can see the size difference. And that's because the egg, once it's fertilized, has to carry all the equipment necessary for the embryo to start dividing. There's no attachment to blood vessel. It cannot get more feed off the mom and any blood supply to replenish itself. So the egg has to carry a backpack on its back with everything it needs until there's implantation. And it also carries the battery pack, the mitochondria that fuels that division. So it has a big job to do. Now, why does the egg change with age? What happens is the egg is not just sitting there. It's actually frozen in time. When you are in your mother's womb, around 5 months of pregnancy, you have the most number of eggs. By the time you are born, that goes down by a lot, from like 6 to 7 million down to about 2 million eggs. So a lot of it die off. The rest is kind of frozen in space. And what I tell my patients is, imagine when we were kids and we played musical chairs and you're about to sit down and somebody shuts off the music and you stay half sitting, half standing, and you have to stay that for 14 years to 40 years. Your bones, your ligaments, they start to snap and crackle. And that's what happens. This strands, it's called the spindle that hold the DNA in the egg, they start to fray. And that's what leads to increased what we call aneuploidy. As this gets old, they just can't present the DNA as well. So when you fertilize the egg, you may get some DNA may drop or some may be added. And we call that aneuploidy. I call it genetic accidents. So while it's frozen in space, waiting to be called up, the egg is susceptible to everything that it's in its environment. If you have too much insulin, it's affecting it. If you have environmental toxin, it's affecting it. If you don't sleep well, your circadian pattern, it's affecting it. If you have stress, oxidative stress, based on what you eat or consuming, it's affecting the egg. Now, so this talk primarily is not about the egg physiology per se, because I could show you the diagram of the egg declining. I think most people have seen it here. So let's swing around. What is going on when you have a derangement in all the things controlling the egg? Now, what we now know is the ovary is not acting alone. And that's what came about just very recently, the paper where they said, well, it's not, polycystic ovary syndrome, because we realize the ovary is an innocent bystander. It suffers collateral damage from other factors in its environment, right? So that necessitated the change where we have polycystic ovary syndrome to PMOS, and I'll explain that in a second more. But just understand, please, ladies and gentlemen, the ovary is an innocent bystander. It's just caught up in what's going on around it. Right. So the ovary is not in isolation. It's controlled by the brain, believe it or not. The master switch, the orchestral conductor and all these things resides in your brain, and it's connecting to a tiny gland that's called the pituitary gland. Now, if you want to know where your pituitary gland is, just do me a favor, put a hand straight through your, between your eyes, one through your head. Where those lines meet is where your pituitary gland will reside. And it's like, almost like two beans way deep in there. Those are the things that control the ovary at the superior level. Then we'll discuss the peripheral level. Now, I'll go on to the next one. So how does the brain control the ovary? Now, if most of my patients that I've talked to about this, I first show them this, and I show them small follicles in the ovary that get, stimulated. They mature into big follicles. They ovulate, and then they close back up. You get a corpus luteum. So in order to understand that, please don't be scared about this diagram. You have to understand that the brain has two mechanisms for controlling the ovary. One of it is called follicle stimulating hormone. This drives follicular growth, right? So the growth of this small follicle here is actually driven by the presence of FSH coming from the pituitary gland, right? And then the ovary, as the follicle grows, it makes the so-called female hormone estradiol, estrogen, that feeds back to the brain. So the brain, all it has to do is sit there and measure how much estrogen is coming through. It can detect it. When it sees that the estrogen is big enough, it knows that the follicle is ready it's mature enough to release an egg. So it sends a second signal called LH. That's what you measure when you measure your ovulation kit. And that signal is the signal that causes ovulation to occur. Now, what do these two hormones do? In order to understand what goes wrong with PCO, you first have to understand that the LH actually drives the production of what we call androgens, the so-called male hormones, while FSH is really driving the estrogen. That's important, right? That's all you need to know from this slide. Now, if everything is working well, FSH is waking up the dormant follicles that I told you about were, in your ovary when you were born. And think of the ovary as its function is a factory. It's a conveyor belt. It's picking up, I don't know if I can put a pen on here and show you guys. Let me see if I can put a pen, laser pen. So it's picking up, you can see it. It's picking up the dormant eggs, putting it on the conveyor belt in the ovary. The follicle's growing, and then it gets to a certain size, right, that it becomes responsive to the FSH from the brain. Now, in one of my previous talk, I already showed that those eggs, they can keep dying even when they are not woken up yet. They can die at any phase in this cycle, but they have to get to a certain size before they start to respond to the brain signal. And then when they get big enough, the brain pops the egg out, boom, you get a dominant follicle, and that's what's supposed to happen, right? What happens instead with PCO is the conveyor belt gets jammed, right? So before I go describe this, if Marlene, you could pop the second poll question, and I'll talk about this more. I want a show of hands. Let's see the second poll question. How many of you thought the ovary in PCO just had cysts in them? 50-50. Ooh, a lot of people had thought about cysts, right? So everybody thought the word polycystic ovary meant the ovary had cysts. Very few people said no. That's something. All right. So I'm going to help clarify this. When we talk about polycystic ovaries, we are not referring to cysts. You see this conveyor belt, right? If I back up to the conveyor belt, if I stop the belt, all these small follicles coming from below will get stuck right somewhere between the preantral and antral follicle. Then it's like a factory. Everything behind it jams up. Now, remember, well, you may not know, but as the follicles grow, they develop a cystic-like area within them. Let me clarify tonight. The word cyst just means follicle fluid field. It doesn't tell you what type of cyst. And I guess that's where the confusion came in. So when you clog up all these antral follicles that have the small cyst in them, on ultrasound, they show up like a pearl of a ring of pearls that you see on the ultrasound. And some people say this is poly, meaning many, cyst. Let me debunk this. This is not polycyst as an abnormal cyst. It's poly small follicles that are blocked. As the follicles grow, they produce a hormone called AMH. So in this patient's, AMH will spike up because they're all backed up on the conveyor belt. Now, and I'll show you how this leads to a disease state, right? So when you back up the conveyor belt, what happens here? No ovulation. They have normal eggs. There's nothing wrong with the follicles or the eggs inside them. Please understand, they're normal. They're just being blocked, okay? So where is the block? You have your small follicle here. That's where it's initially, where it's sort of halted, waiting for menarche to start at age 13. It grows to this stage, and then you see this thing, this light-colored area. That's the cyst that shows up in follicles, right? And a mature follicle has a bigger cystic area, and then when it pops, right, the LH pops it, the egg comes out and this oozes out, this closes back up, and it becomes another kind of cyst, what we call the corpus luteum cyst. So in the ovary, before this, they are follicular cysts. They are not abnormal cysts. What blocks the conveyor belt? We're going to go over this tonight. Insulin blocks the conveyor belt. Excess androgens will block the conveyor belt. And guess what? This is crazy. This is super crazy. This is what we're now finding out. Excess AMH can also feedback block this conveyor belt too. And I'll show you how this happens. Excess LH will block the conveyor belt. And I'll show you how this happens. So this is the block, ladies and gentlemen, that is leading to what polycystic ovary is, where the conveyor belt is jammed. Let me break it down for you further. We have our little conveyor belt coming through, and somebody hits a brake here. The first common brake is excess insulin. And I'm going to explain how excess insulin happens. Then you have another block here, excess LH coming from the brain. And what people don't realize is these ones block immediately. AMH gives a feeding forward brake. It only comes about because you block all these follicles that produce AMH on their own, but too much of a good thing is bad. Too much AMH can actually make the system worse. Now let's talk about, where do you get extra insulin? Why is PCOS so, why do we talk about insulin resistance, right? Everybody knows about insulin resistance. Insulin resistance, think of insulin as a key, the key that opens up a doorway. In your muscle, the doorway leads more glucose to get into the muscle, right? And you need that for energy, for muscle movement and all that, and also to decrease the glucose level. Like if you eat too much glucose, like you just go on a sugary diet, right? Your body doesn't like that. So one of the ways it compensates is by making insulin. Insulin now says, okay, come out the back door, guys. It opens up a key to a storage hangar. That storage hangar is your muscle, right? And then there's another key, another doorway that insulin opens up. Insulin also has another key that opens up a second door in your ovary. These two doors do separate things. In the muscle, it brings glucose in. In the ovary, it opens up a pathway that leads to androgen production, right? It's important for that. Now, let me tell you, in PCO patients, the doorway 1 is damaged. It's damaged because of an epigenetic change that substitutes, you don't need to know this, but it's threonine for serine, and it just damages the door. It is jammed tight. So glucose cannot get in the muscle. As a result, the glucose backs up into your blood. Now, the poor pancreas over here, it can read that there's too much glucose. So it's like, why is the glucose high? And it just pumps out more insulin. It wants to correct the extra insulin, the extra glucose. Unfortunately, the insulin cannot work in the muscle. But guess what, ladies and gentlemen? Insulin resistance in the ovary is selective. So it's in PCO patients. Insulin doesn't work in your muscle. Guess what, where it works? It works in your ovary. So if you have too much insulin, that can't work on the muscle anyway. So the pancreas doesn't know that it's not working. It just keeps putting out more insulin. That insulin goes to your ovary. And if you remember what I told you, insulin has a pathway in the ovary that leads directly to more androgen production. This is one of the ways that you have extra androgen, because insulin is forcing androgen in the ovary. So if anybody asks you, insulin resistance in PCO is selective. It's resistant in the muscle, but it's very permissive in the ovary. It just opens up that floodgate and pours out androgen on the other hand. Now, so we talked about the conveyor belt being jammed. We talked about the small follicles producing AMH. Everybody knows about AMH. It's what you measure. It's produced by the small follicles. But in PCO, we're now finding out if you make too much AMH, it's like too much of a good thing. It can now have a direct effect in your brain. And I'll tell you a second what the effect does. So that effect in the brain results in the brain driving out more LH. Now remember back here, I showed you that LH is needed for androgen production, right? So now we talked about insulin leading to more androgens, but guess what? If I force the brain to pump out more LH, I'm also going to get more androgens. So far, we have two sources of androgens in PCO patients. That's just pouring out so much androgens, flooding it out. One of this is from AMH. So now you set up a vicious loop, especially with AMH. So, ladies and gentlemen, what came first, the chicken or the egg? What led to the AMH and what? So once AMH starts to work on the brain, it forces the brain to make more LH, which forces more of that jamming on the conveyor belt, which leads to more AMH. We go back to the brain. So now we have a vicious cycle set up. So now we know in the new criteria, AMH is now said to be one of the diagnostic criteria that we use for PCO, but you have to scale it based on age. And also I propose that you also have to look at I don't know where you are, if you're in India, if you're in Japan, the lab that runs the AMH may have their own bell-shaped curve. But the bottom line is, if you have an AMH of say 6 in a 25-year-old, that may be okay. But if you have an AMH of 6 or 7 in a 37-year-old, that may not be okay. That may be telling you that this woman is slightly pumping out more AMH than she needs. Now, why does it cause problems for you? AMH, I told you, goes to the brain, right? And it speeds up the brain. Now, how does the brain control the ovary? The brain has a metronome, a tick-tock mechanism. That's how we control how much LH and how much FSH is made. So if I go tick-tock, 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 I'm making normal FSH and a normal amount of LH. If I go tick-tock, 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 guess what? That produces more LH. If I go tick-tock, tick-tock, you make more FSH. So what AMH does is it goes to the brain and it cranks up the metronome. So now I'm doing tick-tock, 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 tick-tock. And when you have rapid metronomic flow of the brain, you preferentially produce more LH. That's all you need to know about. I know my physician friends here will probably want to go into more of the signal, but that's how AMH causes problems. So now we have a vicious loop. That's why the name came. It's polyendocrine metabolic ovarian syndrome. Endocrine meaning the hormones, metabolic meaning insulin, right? Because if you are insulin resistance and your muscle is not doing right by your insulin, that's a metabolic part. And I believe that the ovary, I said, is the innocent bystander. I really think, this is me speaking, that the name should not be PMOS. The name should actually be PMMOS, meaning polyendocrine metabolic multi-organ syndrome. Because multi-organ, the brain, the liver, the muscle, the ovary, right? Ovary is just a bystander here. So understanding all the usual suspects, when we line them up, we're able to now say, well, how can we interrupt this dangerous pattern? So this is where modern targeting can help us target different parts of this, aggressive, vicious cycle, depending on which part of it is revved up. So what's in our armamentarium? We can talk about lifestyle to help, insulin resistance. back in the days, this is where PCO came from. PCO is not a malignant process. It was developed as a result of our ancestors adapting to their environment when food was scarce. So they had to consolidate all their supplies in visceral fat. And they had to make sure that the muscle doesn't soak it up. Because when we need to run from the lion chasing us, we need that big burst of glucose, and we need to feed the brain with that glucose. So it's an adaptation, right? When resources were scarce, we needed that. But then also these people, they worked, they did 18,000 steps, right? Today, we kill our, food in the fridge, and then we go from, the car to the grocery store. So we're not moving as much. So that which helped us adapt back in then is actually what's causing the disease in our modern era when we don't have to run from the tiger anymore, right? So, and then also back in the day when you had to run from people died from infections. So you needed an immune system that cranked up super high, right? And that is the visceral fat, especially the omentum, cranks out immune cytokines that helps you fight infections and help you survive. Now, when you don't have those infections and you crank up your immune system, your body is going to turn on itself, right? So that's where we have the immune component. So knowing all this, we can now start saying, what can we do about it? We have certain things in our armamentarium to help us. One is metformin, one is inositol. A lot of my patients ask me, what does inositol does? So metformin works in 3 different ways. Inositol, this is super cool, guys. Inositol can help unjam that door that I showed you in the muscle. It can also help the follicle respond better to FSH, so it helps the conveyor belt move. Let's go a little bit into more of how metformin works. Metformin stops the liver from making its own glucose, right? So when you decrease the level of the glucose, the pancreas stops panicking and stops putting out more insulin. So it can decrease insulin that way. Another way is, remember that door that's jammed in your muscle where the insulin receptor in the muscle is blocked? Metformin creates a bypass signal that helps the muscle become more responsive. So it helps override that insulin resistance. And another thing metformin does, it can directly block the androgen factory in the ovary. So it's doing 3 different things. So we like metformin. Metformin's good. Now, inositol, here's the cool thing. Inositol also helps to restore the insulin resistance at the level of the muscle, right? And it also can help the follicle respond better to FSH. So it's doing 2 things on the muscle, correcting the insulin resistance, helping the eggs respond better to FSH. But there are 2 isomers of inositol. One is the myo-inositol, and the other one is the D-inositol. D-inositol helps in the muscle, but if you take too much of it, it blocks the ovarian enzyme that might lead to more production of androgens. So you don't want too much of D-chiroinositol. So if you're buying inositol over the counter, you really want to know what ratio they're putting in. If it's more than a 40-to-1 ratio, you are just, you're actually hurting yourself. So let's go on to, so I already gave you 2 things that can help us. Metformin, I gave you how it works. Now we talk about inositol, and this is how it works. There are other things coming up. Do you remember your GLP-1s, your Ozempic, your semaglutide, the tirzepatide? Yes, it helps with weight loss. It lowers insulin resistance. And also, it also helps tone down the effect of insulin at the level of the ovary. That's the MAPK stimulation. So it helps at the level of the muscle, blocks the overstimulation of insulin in the ovaries. So the net effect is to lower androgens. But recently we found out that these products can also go to the brain, right? And they can also remember that tick tock, tick tock, tick tock in the hypothalamus. Um, your GLP-1s can help lower that hyperactivity of the metronome in the brain. And I told you when you slow the metronome down, so now the brain stops pumping out FLH and favors FSH. So this is a novel discovery using GLP-1s to help the tonality in the brain to help drive down. The net result is lower androgens. So what else can you do? You can also do resistance training. We all know that if you do resistance training, it improves insulin sensitivity at the level of the muscle. It helps the muscle mop up the extra glucose in the bloodstream. If you decrease visceral fat, you decrease androgen production. And we have to be careful about telling people about diet because PCO patients are also at risk for binge eating. So that's why you cannot starve your way out of PCO. You actually may need metabolic help with GLP-1s, with metformin, with a structured diet. But please do not starve yourself thinking you're going to fix PCO. You won't. So in an adult, the goal is different. We're looking at targeting movement for young people, 60 minutes a day. In a grown-up, we say 150 to 300 minutes per week will help you hit that target. I'll compare it to the paleotropic age when our ancestors were moving around. Just to give you an example, in hunter-gatherer societies, people move. The exercise for those people is about 150 minutes per day, and they easily clock 10 to 18,000 steps per day, right? So they were active. They could adapt. And one of the things I did not tell you about is when you are adapting to all these things to survive, you create epigenetic changes, right? And when you are pregnant, you have a milieu where your eggs, your fetus is being bathed in high androgen, high insulin. So they can inherit PCO as an epigenetic phenomenon. And that's why you see some people, it runs in their family, even if they're not overweight. So what are the new medications coming out? This, all you need to know, this antagonist, the fenzolintent, is actually approved already for postmenopausal patients by the FDA. What it does, it slows down the tick-tock, tick-tock, tick-tock in the brain. Then another thing is, I told you AMH, if it's too much, feeds back to the brain to stimulate the brain some more. When you give receptor antibodies, you can just snip that and block AMH from feeding back to the brain. Again, slow down that tick-tocking away of the brain. So 3 things we can do. We talked about the GLP-1s that can actually slow down the brain. We talk about antagonists at the level of the brain and the AMH levels, AMH antibodies, all targeting the neuroendocrine hyperactivity at the level of the brain, right? So in summary, what controls this thing? How can we control it? We need to control the tick-tocking of the brain, right? And these are the assets that will do that. We need to help insulin resistance at the level of the muscle and also convince the liver to stop putting out its own glucose. And then at the level of the ovary, we want to snip the AMH loop, the vicious AMH loop. We want to help the follicles respond better to the FSH that's around. That's done with inositol as well as metformin. And all these medications, this is where you need to know what are you dealing with per se, because these medications have different levels of activity. The GLP-1s are very strong in neuroendocrine suppression of the tick-tock. They work in reducing visceral fat, so you decrease insulin resistance through that, whereas metformin is most dominant, suppressing the liver glucose production of its own. It also helps your muscle become more sensitive to the level of insulin around, and may help you with some weight loss. Doesn't really work too much in the ovary, a little bit, yes. And then, of course, inositol, we talked about inositol. It works by helping reduce the insulin resistance at the level of the muscle, and it also supports the follicle to respond better to FSH. So you see now that we have a little bit of a loop. We have brain, too much insulin because of LH just tick-tocking away. Insulin goes to the ovary, clogs up the system. The ovary reacts by pumping out more AMH. AMH goes back to the brain, and now we got a big loop going on. And that's why I say, which came back, the chicken or the egg, right? So, and these are all the kind of themes that I explore in the book, The Quest for Fertility. Definitely the conversation continues. So before we go to the next session, I want Merlin, if you could pop the third poll question there, and let's see what our audience answers. How many new? Oh yeah, that one's I get that one's I threw that one at you. Awesome. So yes, now you can go brag that you know more. Yeah. So I want to thank everybody for being here. But before we go to the next session, we're going to bring in one of our patients to talk about her experience and what she learned as she went through the process of going through fertility treatment. And yeah, there she is. So Lila is one of our patients, and what she went through with fertility, going through the fertility process, right? So if Lila could just explain what you went through going through the process of fertility.
Yeah, and thank you so much for having me here. It is really an honor to be speaking with all of you. So yeah, my name is Lila Sloan Barrett. I have a daughter who's a year and a half old, thanks to Dr. Yemi and her team and through IVF. So I always knew that I wanted to be a parent. I was just something that was part of my life and my future. So when the most common methods failed, my partner and I started looking into medical intervention. We went through my OB, we talked to various people, decided IVF was our best option. And then once we met Dr. Yemi, we had a lot of research to do, which was one of the things I was not expecting. Everything from how many children we wanted to therefore how many embryos we needed to get, what insurance would cover. And I had to relearn about my body and really learn about the reproductive system. I was taught the very, very basics growing up, like I'm sure most of you were, but I thought pregnancy would be easy. And which meant for me that when it wasn't, I thought I was broken. I thought something was wrong with me. And through this process, through having a good team and someone who would answer all my questions and go through, it showed me that the process is really, really complicated. There's tons of factors in fertility. There's tons of factors just like through the entire process. And infertility can be caused from the female and the male side, which I was never taught and I never even thought of before I started this. So moving forward, it was a long and arduous and frankly expensive process, even with insurance. I was afraid of shots and giving myself shots every day. There were weeks where I drove to Montgomery Fertility Clinic every day or every other day. I did not realize before I started that the time and bandwidth that this would take was another full-time job. And it was a challenge, but in the end, it was worth it. It was absolutely worth it for me. And the other thing that I learned and that I think is very important is that um, having a knowledgeable team and a compassionate team on your side, being able to ask questions and have them answered, it really made a world of difference for me and my husband and what is now my growing family.
Thank you, Lila. Thank you so much for that.
So I found the one question
Okay.
while you're looking. Do fibroids function the same?
Say that again.
Do fibroids function the same?
So fibroids are a whole different entity. Fibroids, today we're talking about the hormonal control of the ovary. Fibroids are more structural. They happen in, I don't know if you can see this mold of a uterus in here. I'll stop sharing a second here so you can see me holding up this uterus. So fibroids are in the muscle of the uterus. They could be dab squab right in the muscle. They could be on top of the uterus, or they could be inside like this, and they cause structural issues, right? So what we're talking about is endocrine issues, hormonal issues that affect how your brain functions, and that presents with symptoms. Does that answer that question?
We have also a second question. Thank you.
Mhm.
What do you think is the most likely cause of my miscarriages if all my testing looks normal?
Okay, so again, so could miscarriage be linked to PCO? Absolutely. We know that patients with PCO have a higher incidence of miscarriage, and sometimes metformin helps to normalize that higher rate of miscarriage. However, there are multiple causes of miscarriage, and the most common cause, especially in the first trimester, could just be genetic abnormalities. Remember, I showed you that egg separating, and it doesn't separate normally, and so you have an embryo that results that haven't have the normal chromosome complement that may not be compatible with a viable pregnancy. That's one. There could also be when someone has maybe overall metabolic health is an issue. So if they're sick, that's two. If they have structural issues, if they have, fibroids distorting the cavity, that could be a factor. But then the vast majority of patients who have a miscarriage will go on to have a normal pregnancy. So a lot of times the miscarriage is, we call it, we can't find a reason why you're not miscarrying. And most of those patients will still go on to have a normal pregnancy. So in other words, you need to talk to your doctor. They can actually start a recurrent pregnancy workup to see, are there things that we can correct? And if they do a full workup, they may be able to find something or they may not. But it's not the same as hormonal control at the level of the ovary, right? Next question.
Okay, I see one. What is the ideal A1C, fasting, insulin, vitamin D, and thyroid level before pregnancy?
Oh my goodness. So that's not one question. That's a whole lecture and then some. Right? So if you have hypothyroidism, that can affect the metronome in the brain. That TikTok thing I showed you, that can be affected by hypothyroidism. If you have abnormal levels of vitamin D, we know vitamin D is a supervitamin, right? So most cellular tissue don't work well without vitamin D. Fasting insulin, if you have elevated insulin now, you don't hyper focus on the level of insulin because it also depends on the lab measuring it, right? So you need to know what your normal lab values are, right? In this area, I know what LabCorp gives me, maybe slightly different from what Quest gives me. And by that, in our area, LabCorp may say fasting insulin should be less than 30. Ideal hemoglobin A1C wouldn't that be nice? Is pre-diabetic, and that's 5.6 or less. Does that answer that?
Okay. Can you talk a bit more generally about fertility for women over 40 who are hoping to conceive but are not suffering from PCOS, PMOS?
Okay, so what happens in women over 40, the biggest issue is your egg start to get older. So those mitotic spindles, those spindles I show you, let me go back and share my slide again. Those spindles are what we now know breaks down, right? So I'm going to go back here and find the slide that has the mitotic spindle so that when you are going through cell division, I know I did not start this. Let's go back to take this off. Okay, so you see when the cell is dividing, you see those things that act like drawbridge that pulls the DNA apart? These things start to break down as you get older. That's what happens as you get older. That's why you cannot really supplement your way out of biological age. So I'll show it again. And so when the eggs are dividing, the division doesn't go as well. And when they are being fertilized by the sperm, they have to present the DNA of the egg to match the DNA of the sperm so you could exchange genetic material. Well, if that which presents it is faulty, like those spindles, then you have a mismatch. Again, you get errors in division, errors in chromosome separation. That's what makes it harder to get pregnant as an older age. We can try to supplement, but you cannot reverse age with your supplements. You understand? Now, next question.
What is the ideal A1C fasting insulin vitamin D? You answered that already. Can PCOS go undiagnosed even after many years, and why?
Absolutely. Depending on the severity of insulin resistance, right? Depending on the severity of the jamming of the belt, right? If it's not very severe and you can get one or two eggs escaping through, so you may get, or you may not even ovulate for a while. The reason these women present to fertility or even their OBGYN is when they're not ovulating, and that causes other problems, by the way. And today's lecture is not geared toward that. If you're ovulating but not quite as well, if you don't have a lot of androgen, abnormality, you can just fly under the radar. And that's the problem with PCOS. So if you look at the Rotterdam scale of diagnosing it, there are different phenotypic variants. And that's one of the things I touch on in my book when I talk about the different phases of PCO. Depending on the severity of the insulin excess and the androgen excess, if you don't have a lot of those, you may just fly under the radar. Those are people that have very few phenotypic symptoms. You can go from mildly affected to full-blown raging hyperinsulin and acne, hirsutism. So the milder ones can go undiagnosed for years. And because it can also mimic other problems. For instance, patients who have congenital adrenal hyperplasia, they mimic PCO. Patients who have extra prolactin mimics PCO. Patients who have hypothyroidism mimics PCO. So you have all these PCO mimics that can make it hard to come to the right diagnosis. So your radar really your antenna has to be cranked up in order to diagnose this sooner rather than later. Next question is,
who should someone who suspects they have PCOS seek out to get a diagnosis?
Now, so this new framework of PCO is also helping doctors as well. Because now because they thought, PCO, they would shunt it all to the GYN or the reproductive endocrinologist. Now, primary care doctors or internal medicine doctors know that we're dealing with, I think, again, I call it polyendocrine, it's endocrine metabolic, the metabolic insulin part, ovary syndrome. I think it actually should be multi-organ, right? So if you have extra insulin floating around, your internist should have their antenna radar up your endocrinologist, your medical endocrinologist, your primary care doctor, they should be able to have their radar up. But if not, you can always seek any reproductive endocrinologist who already has their antenna raised and they can look for these things. And by the way, I need to also say that this new clarification, I think it helps another set of doctors. It helps radiologists because I can't tell you how many times a sonogram comes back to me and the patient tells me, oh, the radiologist says I have PCO. I'm like, how? How did they determine that? They saw all these follicles in the ovary. I'm like, yeah, it just shows you have a lot of follicles. It doesn't mean you have PCO if you don't have the constellation. So I'm glad they took that out of the equation.
Okay. Can any lifestyle, habit, foods, or exercises slow down age-related decline in ovarian function?
So what we can do is you can stop making things worse. Does that make sense? So if you adopt a healthy lifestyle and you lower your insulin and you lower your androgens, you stop making it worse. If you are eating more of a vegetarian style diet, you're going to correct some of these abnormalities that we see in a metabolic pathway. And again, this is another lecture for another day, but we also know what we call the microbiome also responds to your lifestyle. And we know that that microbiome can also cause problems at the level of the brain. So absolutely, your lifestyle can help. It helps it stops making things worse. I'm going to say, and I'll leave you guys with this, that my goal is to shed some light. We could go on forever and a day with the pathophysiology, with we could talk about the ovaries, the uterus. As you can see, there is so much that we could easily, this could be a full week webinar conference that we could talk about. So my goal is that I've given you a little bit of information on what's going on in your ovaries, and also to help you understand that there's more to the equation than just your ovary. Like I said, I really think that the ovary is what I call the innocent bystander in all of this. And my goal is that by helping you to understand just a little snippet, that's always ever been my goal. Because, what I did was I put all the things that I wish my patients know about as they come to my office, right? And I hope also that this also helps some of the physicians and the PA students that I see, as well as the GYN residents that I teach. And if you found this helpful, please let us know. We only get better when you give us feedback, and give a review and help the Amazon algorithm push this information to who else might need to know.
Doctor, thank you. I have just two more questions for you. How long should a woman wait before seeking assistance?
So there are clear guidelines about this. Okay. So one of the first is, if you're over the age of 35 and you've been trying for 6 months, please go see someone. If you're under age of 35, you've been trying for a year, go get help. However, if you have a history of ovulatory disorders, like we talked about today, if you have a history of endometriosis, if you have a history of prior surgery, right, that may affect your reproductive organs, then don't wait. What's the worst that you could happen? The worst that could happen is you get evaluated and your doctor reassures you and you get pregnant the next month. But you don't have to wait any number of times. But if you've been trying for over a year, or if you're less than 35, or over 6 months, you're over the age of 35, go seek help.
And the last question, I'm not quite sure if I read this one before, but could insulin resistance or prediabetes increase miscarriage risk even if my labs are borderline?
Diabetes by itself can cause any number of problems. Yeah. So yeah. All right. If you have diabetes, Insulin by itself can cause problems. So yes, yeah, you want to make sure that you correct your insulin. You make sure that you are not diabetic. So yes, that can affect your success rate. Yes. Yeah.
Thank you. I think for right now, that is all we have.
Thank you so much. Thank you so much. This has been really wonderful. Thank you so much for coming to our webinar. I appreciate every single one of you that have come here today. I know you could be doing other things, so I really appreciate your presence. And if you find this useful, like I say, submit any questions that we did not cover today. You can send those questions, and I will be happy to answer those questions for you at a later date.